The placebo response. What's new? We've all heard about the interesting treatment effects of placebo drugs based on the size, color, labeling, and dosing. This implies that it's all about the pill. More recent studies indicate that perhaps it's less about the pill and more about the environment in which the sugar pill or other intervention is given. As Ted Kaptchuk, leading Harvard placebo researcher, puts it, it's about the nonspecifics of care less than the intervention. It's about what researchers try to control for in RCTs and other studies, the noise. It's about the context of care, social environment, and the patient's beliefs that are likely most active in the placebo response. The purpose of placebo studies is then what Kaptchuk calls making the intangible tangible. It's about the ritual of healthcare delivery, which involves in large part the doctor-patient relationship, the attention, trust, and hope. It's an environment that has substantial positive cues. It's about what Kaptchuk refers to as the sacred place, where sick people go to for attention. It's about the design, location, and smell of the office or hospital, and the demeanor of the individuals in that environment. Adding to the belief that the environment may play a greater role than once believed, Kaptchuk conducted a small study in which patients with irritable bowel syndrome were randomized into a placebo group and wait-and-see group. Those receiving the placebo pill were told it was a placebo, and it was labeled as placebo. Yet patients taking it had a greater response to care than the wait-and-see group, even knowing they were taking a placebo. Both groups had a full evaluation and saw a healthcare provider 3 times. Both groups were prompted before randomization with a 15-minute lecture on the power of placebo and the scientific evidence for that effect. The placebo group, though, received the same encouragement at follow-up visits. Although there is evidence that the placebo response is strongest with symptoms such as pain, fatigue, depression, nausea, and performance, there appears to be no evidence that placebo is curative for the underlying disorders for which these symptoms are the result of. For example, patients with cancer may feel less pain, more energy, and less nausea, but there is no indication of tumor shrinkage other than that of normal remission. The best example might be asthma. 2 randomized controlled studies, one using acupuncture and the other manipulation, demonstrated significant improvements in the well-being of asthma patients on average. And although there was no improvement in the objective measure of forced expiratory volume in 1 second, patients on average had fewer and less severe attacks and used less medication, even with sham acupuncture and sham manipulation. Recent studies introduce information that's even more complex and intriguing. The question being asked is, are individuals predisposed to a placebo response? In other words, do genetics play a role in who is more likely to have or not have a placebo response? Before we review some of these studies, let's lay the groundwork for what is known about the neurobiology of one of the most common placebo symptom responders, pain. Let's begin with a quick overview of how pain transmission can be inhibited and where. In the periphery, non-narcotic medications block the release of prostaglandins that can sensitize nociceptors. More recently, anticonvulsants such as carbamazepine or gabapentin are used to prevent abnormal axon-generating action potentials, in particular with patients suffering from neuralgias. At the dorsal horn of the spinal cord, release of enkephalins influence interneurons that block transmission, as does sensory input that's non-nociceptive. At the level of the brainstem, activation of descending pathways from the periaqueductal gray, ventral medial medulla, and locus coeruleus results in the release of serotonin and norepinephrine, which have both indirect effects through release of enkephalins and its effect on interneurons, and direct effects of norepinephrine on primary afferents. Nociceptive information projects to at least 4 areas of the brain above the brainstem: the parietal cortex for localization of pain, the cingulate cortex of the limbic system for the emotional experience of pain, the temporal lobe and hippocampus for the memory of pain and what evokes pain, and the hypothalamus for activation of endocrine release and autonomic nervous system activation. Hormonal release occurs in reaction to pain from areas such as the periventricular gray of the hypothalamus, the pituitary gland, and the adrenal medulla. And at the cortical level, the prefrontal cortex, lateral orbital frontal cortex, and rostral anterior cingulate cortex play a role in relation to expectation and reward and the resulting effects on pain perception. This is mediated in part by the release of dopamine. Now, the circuitry connecting pain transmission and inhibition. In addition to the ascending spinal thalamic system for pain transmission, there are other pathways that influence pain perception called the medial pain pathways. One is the spinal mesencephalic tract. It reaches the periaqueductal gray of the midbrain and also connects to the limbic system, resulting in diffuse, poorly localized feelings of pain and fear. Descending pathways, referred to as supraspinal inhibitory pathways, are activated. Then there is the spinal limbic tract, not shown here, that is designed to convey non-localized perception of pain, resulting in arousal and motivational effects via projections through the midline thalamus to both the frontal and cingulate cortex. And finally, the spinal reticular tracts. These are the oldest of the somatosensory tracts. They originate in laminas 5 through 7 and follow the same path as the spinal thalamic tracts, but only as far as the brainstem, synapsing in the reticular substance. Fibers continue to the reticular activating system, to the thalamus. There are basically two functions: arousal, which is primarily cortical, and most importantly for the placebo discussion, input to the limbic system, specifically the anterior cingulate, about the nature of the stimulus and the emotional response to stimuli. Supraspinal inhibition is conveyed via primarily two descending tracts. The raphe-spinal tract, activated by periaqueductal stimulation, is primarily serotonergic and has its effects primarily through enkephalin release on interneurons. And the cerulospinal tract, which is mediated by norepinephrine, influencing pain transmission directly by blocking primary afferents. Having laid out the structures, connections, and pathways, let's discuss the neuromodulators of pain. In the past, the placebo response was thought to be only opioid-based. Endogenous influence of opioid receptors is primarily through endorphins, which includes enkephalins, dynorphins, and beta-endorphins. Exogenously, opiate medications bind to the same receptors as the endogenous opioids and block pain without affecting other sensations. The role of mu-opioid receptors in placebo pain relief was confirmed in neuroimaging studies a number of years ago. Expectation of relief stimulated activity in key areas in the brain involved in endogenous opioid release and analgesia. More recently, several other systems have been implicated in placebo analgesia, including dopamine, serotonin, and the endocannabinoid systems. There are apparent genetic variations in the processing of these neuromodulators. Treatment outcomes in the placebo arms of studies that determine participants' genetic variation in the dopaminergic, opioid, cannabinoid, and serotonergic pathways seem to suggest that genetic variation in the synthesis, signaling, and metabolism of these neurotransmitters and modulators contributes to the variation in the placebo response. There are some similarities between dopamine and serotonin as evidenced in their role with depression. Release into the synaptic cleft and binding postsynaptically activates receptors, but leaving some unused transmitter. Clearance from the synaptic cleft involves similar mechanisms, including degradation through enzymes called monoamine oxidases or reuptake. Specifically, dopamine can also be degraded by catechol-O-methyltransferase, or COMT, which may genetically be affected, the focus of the study we will soon discuss. We usually associate dopamine dysfunction with Parkinson's, which is related to specific dopamine receptors in the striatum, but the prefrontal area of the brain is also a site of dopamine activity. The prefrontal area is associated with expectation and reward, so there is dopamine release here, but there are differences in receptors and influences. Interestingly, although reuptake is the primary mechanism of dopamine clearance in the striatum, in the prefrontal cortex the dopamine reuptake transporter is less abundant than in the striatum, so the main mechanism that decreases dopamine are levels of COMT. Studies have also looked at a pain model that includes both opioid and dopamine receptor activation in brain regions associated with reward. They showed that both pathways were activated in anticipation of a placebo response, and that higher levels of dopamine receptor activation were seen in individuals with higher placebo response. They also showed that dopamine release in the right nucleus accumbens accounts for 13 to 30% of the variance in the opioid response to placebo. Dopamine is thus thought to mediate opioid analgesia by increasing the drive to seek clinical benefit. So we can see that there may be a synergistic relationship between dopamine and opioids. Personality traits linked to dopaminergic transmission include novelty seeking, harm avoidance, inversely related, behavioral drive, fun seeking, and reward responsiveness. These traits are related to an individual's response to placebo analgesia, as well as structurally related to gray matter density in the dorsolateral prefrontal cortex, ventral striatum, and operculum temporal cortex. It's also been suggested that traits on scales of ego resilience, altruism, straightforwardness, and hostility account for 25% of the variance in response to placebo analgesia. Although we usually speak about reduction of symptoms with a fake intervention, the opposite is also possible and has been studied in relationship to dopamine. Researchers found that in individuals who reported an increase in pain, the placebo non-responders or the nocebo responders, dopaminergic and opioid signaling was reduced. So what about placebo, dopamine, and reward expectation? Electrophysiological studies have demonstrated that activity in some midbrain dopamine neurons is maximal when the probability of reward is 50%, when uncertainty is maximal. And positron emission tomography or PET studies on the placebo response in Parkinson's disease also showed that striatal dopaminergic neurons were activated in anticipation of benefit or reward when a placebo was administered. So in summary, new studies indicate that, quote, the current viewpoint is placebo effects are biological responses to psychosocial environmental cues surrounding the administration of inactive or active treatments, unquote. Although the placebo group in studies is traditionally used to account for improvement due to spontaneous remission, regression to the mean, and the natural waxing and waning of a disorder, a no-treatment control group is necessary. It helps separate out psychosocial and physiological placebo responses to symbols, rituals, and behaviors in the clinical encounter. In other words, a placebo group only is not strong enough. So let's look at a key study in evaluation of the genetic relationship to placebo. The title is Catechol O-methyltransferase Val-158-met polymorphism predicts placebo effect in irritable bowel syndrome. IBS is a condition known to have a high placebo response rate, and meta-analysis reports an average placebo-induced global improvement of approximately 40%. Before we get into this study, what specifically is COMT? COMT is the gene encoding an enzyme that metabolizes dopamine and other catecholamines. RS4680 encodes a valine to methionine change at codon 158, resulting in a 3 to 4 times reduction in enzymatic activity, and therefore more dopamine. Those with less active MET-MET alleles have been associated with higher levels of dopamine in the prefrontal cortex, a region implicated in the placebo response pathway. So we have 3 possibilities: MET-MET, VAL-MET, or VAL-VAL variations. MET-MET individuals have higher levels of performance in cognitive tests which measure executive function, as well as increased sensitivity to experimental and chronic pain relative to the VAL-MET and VAL-VAL individuals. So in this study there were 3 treatment groups: a no-treatment group that controlled for regression to the mean and normal fluctuations in illness, a waitlist group basically involving only diagnosis and observation, a placebo treatment group which used a placebo acupuncture device administered in a non-personal clinically neutral context, a limited placebo arm augmented with a supportive warm provider who expressed confidence in the effectiveness of the treatment. This was the augmented placebo. So in essence, the 2 types of placebo interventions, limited and augmented, could be considered analogous to a dose-dependent comparison in the relationship of time and attention spent with a healthcare provider. COMT predicted responses in only the augmented placebo arm. In response to a high-dose placebo treatment, patients with the MET alleles, MET-MET, showed the greatest improvement. VAL patients showed the least improvement, and VAL-MET patients had an intermediate response. Placebo response to pain in healthy volunteers was studied, and the results supported the IBS results, again indicating that the number of RS4680 MET alleles was linearly correlated with suppression of pain in a placebo expectation laboratory design. Let's look at one more study, somewhat related, based on a gene-based relationship to depression. With depression, a similar degrading enzyme has been found to affect placebo. Monoamine oxidase A levels in the brain were measured using PET scanning and were elevated by an average of 34% in patients with major depressive episode. Similar to the findings of the COMP studies, individuals with the low-activity MAO-A genotypes and therefore higher basal dopamine tone had a higher placebo response than those with the high-activity MAO-A genotype with lower dopamine. So this new information taken together creates more questions than answers. For example, what is the relationship to placebo, genes, and medications? We know that certain individuals are genetically predisposed to have a stronger or weaker response to certain medications. Here we see some examples involving a wide variety of meds used for treatment of epilepsy, anxiety, pain, depression, and diabetes. So in a study evaluating the effectiveness of a drug, several scenarios could occur that might falsely affect the interpretation and results in comparison to the broader public not in the study. For example, what if in the drug treatment group there was a disproportionate amount of individuals with a gene makeup that left them less likely to respond, coupled with genes that decreased their placebo response? The drug would appear less effective on average. Or the opposite, those with genes for high responsiveness coupled with genes for a high placebo response would make the drug appear more effective on average. If by chance in trials where the placebo response is known to be high, there are more genetically predisposed placebo responders to the placebo arm than in the drug arm, the estimate of drug effect might make the drug appear less effective when compared to placebo. So this begs the question, in the future, do RCTs for interventions need to balance the participants in each group based on genotype? Further studies of the placebo effect will likely not only change how drugs and other interventions are studied, but also significantly change how we practice, in particular, how we interact with our patients.